All right. So welcome back, everyone, to, I believe, our final Coffee and Conversations. Greetings from Michelle, who is presenting at a conference today. If you don't know me, I'm Megan Eagle. I'm one of the other faculty members in the Office of Global Affairs. I'm the Deputy Director for our PAHO WHO Collaborating Center. And today I'm very pleased to introduce to you Naruemol Singha-Dong, who is a professor at the Sarunari Institute of Technology, which I probably said wrong. We always call it SIT.
SUT.
SUT. Okay. Oh, that's right. You're a University of Technology in Thailand, and she is the interim associate dean for academic affairs at the Institute of Nursing. That's where I got institute. She has her PhD in nursing from our very own University of Michigan, with a focus in health promotion and risk reduction. Her areas of specialty are community medicine, health economics, health promotion and risk reduction, community care. But her focus is within these areas is on non-communicable diseases and nurse case management of NCDs. She does also have a specialty in epidemiology. Today, she's going to be talking to us about hypertension in Thailand. She does a lot of research, including sort of health systems research related to Thailand, as well as health promotion and nursing intervention research. And so without any further ado, I will let Nar introduce herself. And welcome back, Nar. It's always a pleasure to have you with us. Nar, you are on mute.
Yep. I'm trying. Thank you. Thank you for the introduction, and good morning, everyone. Today, I'm very pleased to be able to share with you about a story of NCD in Thailand, especially for hypertension. The request that I got from Michelle is that I can focus on my work, but I would want to also give you a sense of NCD in Thailand. So today I'm going to talk about NCD situation and then the health service system, because I think if you don't understand the health service system for Thailand, then you might not being able to figure out like what's wrong and what works, what doesn't work. And also you'll be able to compare and contrast with the system in the US as well. And then I'm going to talk much about my contribution to NCD, especially hypertension control in my area. So my interest in terms of intervening with hypertension control would be in the aspect of smart health, and also the use of chronic care models, and also integrated health system research. And then I'm going to talk about the challenges that we have in Thailand, and I think also some similarity from other countries as well. So when we talk about focusing on Thailand, then for the Thai NCD profile, in the past, right now we have about like 70 million population right now. And most of us is just like low to middle income people. And we do see lots of incidents in terms of NCDs, and especially in the beginning, we see a lot of death from traffic accident. But afterward, like the past 7 years, we see more of the NCD prevalence and also death from NCDs. And when we take a look at the ratio of disease and also proportion of mortality in Thailand, we see that we have high number of deaths, that 71% are from NCD. And when we see the trend of mortality by year, this is as far that I can go in terms of like the most recent data that is green and can be used. So from 2014 to 2018, we see lots of mortality that cause from NCD. We see low number of hypertension, but at the same time, hypertension is just the beginning of our vascular diseases and other issue that may come forward in terms of health and also in terms of health economic and impact to the person, the family, and also the society. The recent research last year that's published last year, we saw that we have about like 12% increase in our OPD case. So in Thailand, in the past, when people are very poor control, they will be admitted to the hospital. But right now, because of the health system, we will be able to set up the NCD clinic. When I said NCD is most likely to be DM hypertension with other diseases, but the best underlying disease would be diabetes and hypertension. And we see lots of increasing in, this is before the COVID pandemic, but we still see high number of our outpatient visits according by hypertension. And the country also have surveys. So the Ministry of Public Health conducted National Health Examination Survey, and we see lots of determinant of health, and then also the disease already occurred. So on your left, then you see risk factor of NCD. So we have higher proportion of people who are obese. And then also we do have people with hypertension, or this is like the number in red is million units. So we have 17 million people who are like chubby, we cannot control for BMI, and then also we have abnormal obesity, hypertension, and also other condition. We do see, it seems like we have fewer cases from our CVD and also stroke, but when we count it as one person can have more than one underlying diseases, then sometimes we just add it up. And sometimes when people are age and die at home, sometimes they don't get diagnosed for cause of death. So this number raising awareness about what actually the cause of death in Thailand. In the last 7 years, they also have the Thai Ministry of Public Health had also do the survey for cause of death by death certificate, but it is not conclusive about what actually the cause of death. And also when we talk about the prevalence of CVD factor, that people have trend, Thai people, I think the Thai population just follow the US and Western country in terms of health behavior, and also how they have their unhealthy lifestyle. So we have more than 22 million people who have drink alcohol. And then also regular smoker, almost 10 million people. And then we have, even though we have very good policy in terms of smoking ban indoor, and also the policy that we increase tax from smoking, from liquor and then cigarette, but still we still have high number of smoking in Thailand. And also we do have people with inactive, and then also we have people that have unhealthy food and vegetable habit. When we talk about the Thai health system, actually in Thailand we use the try to do the networking approach. We do have what we call contracting health unit within the network of the district and also the province. When we take a look at each level of health services, then we will see at the community level, we do have lay health personnel that we train them for 28 hours at the beginning for like the basic health assessment, vital signs, and then also conducting questionnaire about risk behavior and also collecting data about family risk. And that's the beginning of the 28 hours. And after that, there will be monthly training, additional training from provided by the primary care setting. So at the community level, then the primary care setting work at the sub-district level, and this sub-district catchment area would have a population no more than 10,000 people. And for secondary, I think this is misspelling. This is secondary care setting. For the secondary one, they divided into 3 levels. So the primary level of secondary healthcare services would be responsible for a population about like 30 to 50,000 population. And then the second level of tertiary care, the care would be about like 80,000. And then for the third level of this care, then we have be responsible for 200,000 population. In this level, we do have people that are not people like healthcare specialists in the area. So the hospital would have about 120 beds per hospital. So it's likely to be the bigger district, and then also a small to medium size of a provincial hospital. And for tertiary care hospital would cover the catchment area of population about like a million population. For excellence center, for example, we have hospital, university hospital, excellence center in healthcare. These centers are responsible for about 2 million population. How we divide the number of population, that's based on the primary care setting would be first responsive setting, and then the secondary, tertiary, and then excellence center, and we use the referral system. And when we take a look at the right-hand side, the Thailand map, we will see that our healthcare personnel usually cluster proudly in the big city, for example, in Bangkok, Chiang Mai, and then Phuket and southern area. We do have some cluster here or at the border of Thai and Lao PDR, and then a little bit over here for a border of Thai and Cambodia. And for the health service system for NCD, then Thailand pretty much adopt the chronic care model, and right now we adopt the extended chronic care model, where we stress so much, focus much on the primary care setting, especially in the community level. So public health and community health care are the main focus in the community level. And then for the health system level, then we do lots of how to build self capacity to care for themselves, and then we do have training for family members, so they can have family members who are trained in specialized in terms of not specialized, like the focus on the need of their family member. So we have family member provider, and also we do have lay health personnel in the community level. And then we have a nurse, mostly would be nurse practitioner who work at the primary care settings, like the primary clinic, who would also see the patient, especially diabetes and hypertension, and they can prescribe medication for the patient who can control for the disease. But patient who cannot control for their condition, then in some province, we have an agreement that there would be mobilization of the family medicine family doctor from the district hospital to the community clinic. So they rotate like that to provide services so that the patient do not have to travel all the way to the city and waste their time and spend their money for traveling. So we more focus on, especially for the rural area, so that we can ensure that people have access to needed care. And what kind of services that we provide at each level? For the primary level, like primary care level, we do have the Thai government provide funding to the local administration to do what we call PP, prevention and protection fund, to focus their work on community-based activity for screening and prevention, for example, promoting physical activity and also doing basic screening in the community level. And then they also have local government funding that will be responsible for lifestyle modification, healthy environment, and also management of risk factors. And this is most likely focused on pre-diabetes, pre-hypertension, and diabetes with hypertension people. For secondary prevention, then the focus would be more on the screening, early detection and treatment. Here at the sub-district level, we do have nurses, registered nurse, and also nurse practitioner who do their assessment and screening with the help of the healthcare worker, so that the healthcare worker especially is the lay health volunteer. So we do, in the past, we provided the screening at the primary care clinic. But right now, this year, the government has, because due to the COVID-19 as well, so this year we do have the report that say that we have very poor control of NCD. So we started to piloting the healthcare post at the household of the leader of the community or the leader of the lay health personnel. So people can just go to a house, maybe the healthcare post in the community, to get checked up. So they get the blood pressure taken. They can also have like random sugar testing before we screen them and then send to the primary care setting. And if there is something that indicated the need of further investigation, then we do have the consultation system with the family doctor and also the nurse practitioner to prescribe for labs and also medication that needed. But nurse would focus more on behavioral modification aspect. And if the preventive measure doesn't work, then we go further to working with the family medicine and also for the people who specialize in NCD, especially for diabetes and hypertension and CVD. And we see more higher trend in terms of, getting to see people with chronic kidney disease. So the target of Thailand, when the patient has came to the end state of renal failure, then we still try to have people with the health insurance team to do more of the CAPD than do hemodialysis. And then they can do it at home and also after with the help of the healthcare personnel at the primary care clinic. For people who need hemodialysis, then we work with the nurses. Nurses would work with the local administrative office to assist the patient with how would we provide transportation for the patient to be going to the clinic to do hemodialysis, so that the family member do not have to take day off from work, and then it won't be burden to their well-being and also their economic. So we do have this kind of funding and this kind of scope of practice in the Thai health system. So in summary, we would say like the Thai health system would try to do the lifestyle modification, and we do have lifestyle strategy plan, try to build the competent community to be able to notify risk and also be able to access the need of care and the need of the diagnosis, and then using referral system to send people for care. And at the same time, the government also need to provide funding to follow providing care. At the local level, then we do have the provincial and district health board to monitor the change in terms of prevalence control and also other diseases that might increase the burden of NCD. So the budget would be like this, and I would give my handout later on. So sorry that I used the Thai letter here. I would like to tell you a little bit about our care system, our health insurance in Thailand. We do have people with private insurance, about like 10 million people. We have about like 5 million people who have their profit, the health profit, and also support, not profit, health support as their work. So the people who work for the government or military would get this kind of insurance. And then we have social security fund for people who are in the industry. And then also we have the universal health care for general population who are not eligible for other health scheme. So we have about roughly right now about like 42 million population. And then also they use people who are poorer, then use more of the inpatient services in the past. And then people who are better off, then they use more of the outpatient department visits. And we do have lots of our economic burden in terms of our medications and also treatments. I'm gonna skip so that I have more time for discussion. When we talk about how far did we go, or whether or not Thailand can achieve the goal for NCD control that we have commit to, then we still cannot achieve the target of NCD control. We still had lots of economic loss in terms of our healthcare expense for care for people with NCDs. And I think it is like global bad news when we have our COVID-19 pandemic. Then we saw that lot of service change and service modification for the Thai health system. Then people has less visit to the NCD clinic, and at the same time, people have less people are less likely to be able to get access to exam their health condition, and then they get piece of information about their clinic, because they have to mobilize their healthcare resources to for COVID-19 related care. But at the same time, because of that, our patients stop coming to our primary and secondary care clinic, and especially tertiary care hospital, because the risk of COVID-19 and because of the limited resources. So in Thailand, we do have like health volunteer, Grab Ducks and Grab Bite. So we deliver medication to the patient at home. And then the volunteer would also explain the health situation of the patient, and also tell them what to do, and then when to go back to clinic to meet with the nurses and also the doctor. At the same time, we also do have the approach that we have been doing in terms of community-based level. Then we have two that my work in the past has been on community-based intervention, and because of that, I was able to bring my student with me for their community clinical practice, that we also do the same similar assessment to the community in terms of individual level, family level, and community level of needs in terms of NCD care and in terms of wellness of the population. And the tool that we use mostly when we provide care to the patient, when we summarize the care and then also the health outcome, then we provide the health personnel and the primary care clinic with the community maps. When we locate, the pink one is the household of the health volunteer. And then we also use color for people with some kind of diseases. And you will see like some color here. Some household has few colors because the family member of that household has more than one disease, or maybe one person has more than one disease. And at the same time, when we talk about managing the list and also identify the individual risk, the family risk, and also the community risk factor of the population, then we use genogram. My student would do the village level, I would do the sub-district level. And I will provide the tool for the student, the same tool that I use for my research, but the student would use that for their project in terms of the practicum. And we use the genogram, like single family genogram, to identify incident of the disease, prevalence, and also at the same time the risk of the family member. And then also this is like what my students had when they do assessment of the community. So this is like hypertension. In my area, especially in the rural area, we see lots of hypertension. Sometimes in some communities, some villages, we will see about like 45% of adult population that has high elevated blood pressure, and with 30 or to 50 of them that has hypertension. So sorry that the slide jump around. From the individual level, the family level, then this one is also when we group the family genogram together, and then we get the community-based genogram. In the Thai context, we usually see in the rural area that the neighbor are those who are relatives, and they also are close of kin. So we see the same pattern of risk, and then we just try to reduce the risk of the population. So what we did is just that we just try to go with the route. So this is like we've seen lots of rising trend in terms of stroke, so that we just try to eliminate, just try to reduce the risk, and then one of the risks is hypertension. So when we when we get, this is our community-based intervention. When we get the community level information, then we share with the family, especially the family with the risk. And then my student and student are, sometimes they act as my research assistant, and sometimes they are just on their practicum. So there are, which is like on different event. So the student and I would present the situation to the community, and then they decide whether or not that the situation is a threat to them, and they came up with a plan on what to do or what target they should achieve, and then when and who's going to do what. So we did lots of the community-based intervention in the community level. And in this picture, you have seen some of the UM alum who came to the community, and then also did community-based intervention with the family of hypertension. Just like 81% of family members who are adults has hypertension. And then what we try to do more is about how we have people understand better about health information piece, especially what to eat and what not. In the rural area, it is better to pick the piece of information. So we just try to tell them this kind of fish sauce had what amount of salt and sodium in their food, and at the same time, vegetable that grow in the area, because Korat is the name of my province, is based on the South Basin area. Then we are not quite sure whether or not that is one contributor to the high level of our sodium in the consumer side or not. But at the same time, we just try to educate the population about vegetables that have a higher level of purine, higher level of monosodium glutamate, sodium, and also other food that are concerned in terms of unhealthy food. My later project that I have done, or one of the projects that I would like to tell you is the big program that called technology and innovation for the prevention and care of the NCD in Nakhon Chhaiburi. Nakhon Chhaiburi is the cluster of provinces, like 4 provinces in my area. So my province is the major focus, the bigger city, and then we have 3 more provinces that are in the same health zones. Our focus is on hypertension, chronic renal diseases, CVD, mental illness, and other CVD stroke. And we do have focus on lots of issue. For example, we have lifestyle modification, where faculty from nursing, public health, and medicine has worked together. We do have food for chronic illness, when we do have faculty from our Institute of Agricultural Technology who are in the food technology. They would come up with food that is reducing the level of sugar and also sodium. And also we do have people from digital technology and also people from the service element. So this is like the service system in the area. And then we do have screening tool and health information. So our illnesses that we focus is what I just told you, and then the theme would be like food screening, behavioral science, and early detection. And we do have about 29 faculty member of SUT who work together in 15 sub-project. And we ask for the national fund, and we get some funding, not all, but we get enough funding to start the project. So I did more of the CVD and stroke screening, and then pathology of the MVD. And then my other faculty member would do psychotherapy for DM and also dementia. So we just work together for that one. And then later year, we know that our project, our research outcome show a little bit change, but we don't know for sure why. We cannot help the population to improve the control of hypertension. So last 2 years, I've been focused on life rhythm. So we use our smartwatch for we ask the patient to wear smartwatch for 2 weeks, and we see our sleeping quality, we see life rhythm, and then also physical activity like exposure, and related that to the level of hypertension control. And it's almost ready for publication. Another project from our faculty member is that we are using imaging, like she tried to develop the application, use her smartphone, both Android and also iPhone, to access the ankle brachial index for patients with hypertension or dyslipidemia and other diseases. So of those, we do have people in lots of areas that have been focused their research, but all in all, both the work from the health service system and the work from researcher, then we still cannot achieve much of the NCD target. But this is very poor in terms of hypertension control. We have the target of reduce the incident to 16%, but we still have the rising incidence of hypertension. And then from our outcome last year, you see that this is like health zone healthcare zones, like from zone 1 the northern, and then the zone 9 is my area. We still be under the control of 60% target. So we just we have to work more on those. And because of our outcome last year, then this year we try to monitor on how well we follow up on the high risk group, and then how well that we should, so that we can prepare, and then we have come up with intervention. So the only one that we can have is just that we have a viable, affordable basic technology and essential medicine, so people get access to medicine easily. But at the same time, we do have challenge in terms of sometimes we do see like the easier the access to care, people are more likely to ignore their contribution to their health. I'm not sure whether or not you observe those in your country, but for us, when they have to co-pay, they are more careful about their lifestyle and also their health. But when they have just free service for the needed, then they just unlikely to comply and also unlikely to control. So we still need to work more in terms of the lag between data that we have. We do have health data center, but we just need to clean it a lot. And then we also have the question about whether or not it has the exceptional quality, and also whether or not we use those information to plan for future intervention. And we still have higher debt in terms of NCD, especially for vascular-based diseases, and then the service, most likely at the country level, the data are somewhat unreliable. And then our other challenge would be the use of, I think this is the same thing that I forgot to delete. And then other thing is that the commitment, because At the same time that we need more funding to control for the disease, and then to also help with lifestyle modification. The industry also need to make profit from liquor and also cigarette. So those conflicts also rise in terms of like how well would contribute to the control of NCD. And we still have the interference between industry and public policy making. At the personal level, where we have the most challenge in terms of hypertension is the asymptomatic nature of hypertension. People don't recognize the symptom. They don't think they have the disease. People do not want to seek screening because they think when they screen, they get a disease. If they don't screen, they don't get disease, especially people in the rural area. And then this is what I already told you, is about like the salt basil. And I think that's it for my presentation. So I'm open for question and discussion.
Great. Thank you so much, Nar. That was great. I had a million questions as you were speaking.
Thank you.
Narcissa and Jen have each put questions in the chat, but did you all want to just unmute and ask yourselves? I will give them a moment. I'll go ahead and start us off then with Narcissa's question. Oh, actually,
Okay.
you unmuted. I will let you ask your own question.
Thank you. Thank you for the presentation. It's fascinating to hear about what's going on in Thailand. Earlier in your presentation, you talked about the nurse practitioners being used in the rural areas. My question to you is, do they have the full practice authority? Because you did mention that they were able to write prescriptions for their patients, but are they under the delegation of an MD, or do they have the full practice authority there in Thailand?
Thank you. This is very interesting point. We have been, I think in Thailand we still fight for that. We don't have full authority for that, but in the provincial level, we do have an agreement within the healthcare service system that for diagnosis, then the MD would need to do that. But after that, if people are within the range of control, the nurse practitioner can do that. But if the control is somewhat good, for example, they have not so good control, but not so poor control, then to very poor control, then the nurse has to consult with the MD. But our consultation system, we don't need to send the patient to the hospital. We do have in Thailand, it is very popular that we use LINE application. It's just like the open chat, like one form of the social media. When we just ask the doctor, we do have essential medication at the primary care clinic. But sometimes we do have lists of medication that nurse practitioner can prescribe. But after than that, for those who are stocked and available, then we just need to consult and then have some kind of evidence saying that, okay, you just can't give it out, with me saying that, me as a doctor saying that this is like, it has been notified and it has been approved. So we do have about like enough coverage of exemptions list of medication that nurse practitioner can prescribe. And at the same time, because we don't have many number of healthcare workers at the primary care clinic, sometimes people who are not nurse practitioner, for example, registered nurse, and people with public health authority might be able to do some very basic prescription as well.
Great. So it sounds like within a limited formulary, you can act with independence. And when you're beyond that, or a patient is not responding to treatment, but you actually can use an app and text with the doctor, basically. You don't have to have the patient go to town or something.
Yeah, and then most of the time when nurses then prove themselves that they are competent, Then sometimes when we ask doctor, it's like, do you think this patient should be treated like this? And then it's just like, okay, go ahead and do it. So actually, but because of the medication list is not within our authority, then we just need the green right to do so.
So Jen, you had a great question also.
Yeah, I was wondering if you could talk a little bit more about the Grab Drug program with the motorbikes and delivering drugs to people, like how it's funded, like what kind of training the employees have, how many patients they're responsible for, or how patients become eligible for that program.
Okay, thank you. Well, I can talk a little bit back to the basic. One health volunteer, like the layperson health volunteer, in the Thai system is responsible to 8 to 10 or maximum of 12 families within that catchment area. So one health personnel would be in this village A. Then if that within that catchment area, if there is a patient, then the health volunteer would provide basic delivery for medication or medical supply, and also maybe some kind of template or any kind of piece of information to people who have health needs in the area in some setting. In some setting, it depends on the province, how they set up this one. In some setting, they said like our population are, in general, are more healthy. Then we don't need every health personnel to go through every household. So they just like make the routine schedule about like the first week it will be this person, the second week there will be this person. And we do have another health volunteer that we do for the Grab medicine, is that we also have what we call caregiver program. When we train health volunteer for 180 hours, so that they can provide a little bit more services in supervision of the registered nurse and NP. For example, they can do, you can take vital signs. They can also provide blessing to people who are bedridden, something like that. And then they also can be able to ask about symptoms and also well-being of the population. And it depends on the province setting, but we have the same system throughout the country where the health volunteer would just grab bike, have their bicycle, and have a pack of medication within their bike. The government subsidize the gas price, and also the health volunteer would get additional payment, especially during the COVID-19, because they also have, at the same time, they do have to also screening for COVID in the population when people have mobilization, people who, stranger or other people would come to the community, they do need to also do screening and something like that. So it depends on the setting, whether or not they will just like dispatch which volunteer to do what.
Great. We have time for, I would say, 1 or 2 more questions. Yeah, Narcissa.
So to piggyback off of that, do you all have home health services or home health care in Thailand? Because it sounds like you do a lot of volunteer work and do a lot of volunteer hours to learn how to care for patients and just teaching the basics in healthcare. But is there a home health program set up there?
Thank you. We do have that, or in the primary care setting, we do have our home health care. We also do have school health for maybe students with health needs, and we also have temples health when we provide care to monks, and also we do have what we call our occupational focus is not industry. So we do have the same thing, but just like basic screening would be health volunteer. when they found out, for example, that person has elevated blood sugar, elevated blood pressure, then they notify the nurses. People with the complex needs, then the nurse would also more complex need, then nurse would be the focal point to provide home health care. But people with complex need, then we usually do what we call community grand round, when nurses with the doctor and then the pharmacist and sometimes with nutritionists also provide home visit to the patient, and then to the family and to the patient. We just try to train them to do self-care in the limit of general population. And then other than that, then the healthcare personnel would do that. And most of the time in my practice in the area, when they did grand round, then they invite me. So I went with them to do grand round, and then we just connect those with more specialties. For example, we have some MD at the university hospital, then we can consult in some cases, something like that. And sometimes we invite local administrative officer to go with us in case that the family member or maybe the patient need more help in terms of like their living and also their economics issue. And when we see that at the primary care level, we cannot provide care that fit their need, then we just use the referral system to send them to the district hospital or provincial hospital.
I have a question for you on a different side of your topic, which is that you mentioned that you're not seeing the impact, quite the impact that you had hoped for when you're looking at the individual behavior change interventions, and that you feel like there is more that other sectors could be willing to do. So can you speak a little bit more to that? Because we had a really fascinating presentation during the Summer Institute from Chile, where they were finding sort of a similar thing. Not that it wasn't worth doing the interventions, in this case, around weight gain and obesity and pregnancy, because there was a small change, particularly in those most at risk, but this sense that at the population level, there are other things, other forces at play. So what are your thoughts for Thailand? What are the important other sectors that should be involved in changing the picture with chronic disease?
I think there would be at least two major reasons for that. The first one would be before the pandemic, we have been very good in terms of physical activities, promote physical activity, promoting lifestyle change, and also at the same time save more environment. But after the pandemic, these people just like sedentary. This is like additional problem that people just cannot control for the disease. But I think one major thing though, according to the intervention and then our program, is that we have very few programs that target the prevention and risk reduction, but we have more program in terms of treatment. So for the prevention, we saw change, we saw significant change, but it's just like little change, not big change. And when we as a researcher came out from the setting, from the community level, then we need the work from integrated work from several stakeholders to take place. For example, we just need the health service system to fully mobilize those and then follow up and monitor those. And at the same time, we need also the local administrative to provide more funding and for more contribution to the work so that people would get motivated to do more. But sometimes it doesn't happen because not only motivation, but because like especially these 3 years, the people they are the same group of people who has worked with NCD control, that we mobilize them to work more on COVID-19 control. And then it's just like we have this amount of money, we have this number of resources, then sometimes we just need to pick one way to another. But I just think that to improve the control, the program that might work better according to our study and also observation is that we just need the program that are long-term, and then motivate people to change, and then rewarding the change, and then also being the first pilot setting that can work more and gain more. Right now we just get 3 applications from 3 villages that are very, very good in terms of have a good ground in terms of social mobilization and social resources, and are very strong that they want to work more on the control of NCD in all levels. So we just think that we will go in the future work, we go with the 3 villages, and we see like if we can do it long term.
Yeah.
Then whether or not we have more evidence on the control, and then more permanent control of those.
Yeah, no, that's a great point. When you're working on something that's connected to so many aspects of people's lives and health issues and risks that have built up over a couple of generations, it makes sense that you need the perseverance, you need the long-term commitment to the programs, and to trying to intervene, because it would be sort of funny to expect, a 3-month intervention to change habits that have built up over 3 decades. Yeah, great. Well, any other final questions for Nar?
I'm open to anyone that who want to come to Thailand and then work with me or work on their project in contribution to hypertension control and NCD control.
I would encourage everyone, if you do have a chance, our students who have worked with NARS research and with NARS students have learned an amazing amount. And as you probably heard within the presentation, it really is a very different health system and a different approach with a lot that can be learned. So thank you again for your time. Thank you, everyone here in Michigan and around the world, for joining the Coffee and Conversations series. And Best Day, do you have any final messages we need to communicate to our group?
No, I think this is the closing of our Coffee and Conversation series. So I'm really excited, hopefully, to do this again next year. I don't really have anything else. Nar, thank you for this wonderful presentation.
Yeah. And thank you, everybody, for your engagement and your questions and making it a conversation. It has been really a pleasure to see our own students, but also our colleagues, students from across the world, and many of our colleagues joining us. We hope to carry on this tradition every summer. And thank you again, Nar, for ending us on such a great presentation that really combined your specific research with great background knowledge on the context and the health system.
Thank you so much for inviting me, and excuse my accent.
Oh, it was great. All right. Well, I will leave this open for a moment for those of you who are waving goodbye or putting goodbye in the chat, and have a good day or sleep well.